years, we've been on the top 10 list of the Newsweek as the best hospitals in the world, and we're very proud of it. And lastly, this year, we've been also on the list of the smart hospitals of the world. We've been listed as the 13th hospital. And one of the reasons for choosing us to be on this list is because our vast telemedicine activity. So what exactly is telemedicine, or how do I see telemedicine and what we do in telemedicine? So basically, telemedicine is connecting between a clinician and a patient that are not in the same physical space with use of technology. And really the backbone of telemedicine is the real-time virtual visits, preferably video visits that can almost simulate one-on-one, one-to-one, face-to-face visits. So I think the best communication you can have with your patient if you're doing a real-time virtual visit is doing a video visit and not only phone call or texting. This gives you a lot of value, but the ability that we have nowadays to monitor patients in their homes, sometimes even just by a smartwatch or another sensor, gives us a lot of extra value from what we do in telemedicine. We can actually, for the first time, know what happens between our physical encounters. A chronic patient can see his physician one in every 3 or 4 or 6 months, and we just have absolutely no idea what happens in between. And if we monitor our patients and if we send them questionnaires, we can have objective, actionable data. We can sometimes make better decisions. And we can also see if the patient, for example, deteriorates between our visits and raise a flag. And the third thing we can do with telemedicine is asynchronous visits. Is there a way to
apologize? Could everyone please mute your phone? I hear there's people talking in the background. Thank you so much. Sorry.
Thank you. And the third thing, so I said real-time virtual visits, which is really good communication between patients and clinician, remote patient monitoring that gives us a lot of value and allows us to make a good continuity of care. And the third thing is the asynchronous visits, what we call store and forward. A patient can download his own information, write his notes, send to a physician. Even if he's in a different time zone, he can react at his own time. And this gives us a lot of flexibility. So actually, these 3 basic things are what gives us a lot of value to telemedicine activity. And I really like this quote talking about telehealth or telemedicine holding a very big promise. It has the ability to transgress all the barriers mankind has erected. It looks really nice, geographic, time, social, cultural, political, and really giving it the potential to decrease inequity in healthcare, to be able to provide support for healthcare support for anyone, anytime, and anywhere. Looks really, really nice. And actually, there's a lot of evidence that shows us that telehealth can have very good positive outcomes. We've been doing telemedicine for decades now, and we have already evidence that shows that it can decrease mortality, increase quality of life, reduce hospital admissions. If you look here at this table, you can see that we have a lot of evidence, strong evidence, showing it's good, especially for chronic disease, cardiovascular disease, diabetes, all other chronic conditions. So it's really, we know that it's good nowadays, and it has also other benefits that have been shown in the medical literature. It can save time and it can save money, and moreover, usually patient satisfaction is very good in telemedicine programs. So why then, although we've been doing telemedicine for so many years and it's such a good thing, why did it not become real medicine? Until COVID-19, it only, was anecdotal. Even us in Shiba that made a lot of efforts in promoting telemedicine program, we did not hit the mainstream of medicine. And the answer is, of course, there are many challenges to telemedicine, and I'm sure all of you now trying to deal with the hospital at home issues, you will understand what I'm talking about. You feel what I'm talking about. people will tell you technology is not a barrier, but I can tell you I'm a physician, I'm not a technology person. Technology is a barrier, especially when you work in a state hospitals, and the platforms have to talk with each other, the integration between different systems. Maybe you have Epic, which is more flexible than what we have now, but to integrate telemedicine technological platforms or remote monitoring tools to our EMR is really, really hard. Of course, finance goes with regulation. Regulation has to allow us to get true reimbursement for what we do. And until recently, in many countries, I believe in the United States as well, not everyone could be paid for giving telemedicine services. I know CMS did not allow reimbursement for patients that were not really far away, or just for really, really very little or narrow aspect of medicine services. You also have to make sure that your patients have accessibility to internet, have smartphones, are tech savvy. You have to make sure that they know the language you talk, they can read and write, and accessibility is really an issue in promoting telemedicine services. I think the ethical problems are not so big. Those of you who are clinicians meet everyday ethical challenges, and I think the difference in the challenges are not so big between telemedicine and inpatient or frontal services. I do believe we have to know our abilities, to know when we cannot see exactly the full picture, when we are not sure enough that we can make good decision, and then we have to call our patients in or go to their homes when they cannot come. And of course, there are privacy issues that I'm sure all of you understand. We just had a big cyber attack on one of Israel's largest hospital. It took them more than a month to recover. So I can tell you, you have to make sure privacy issues are not disturbed. So these are the reasons why telemedicine did not hit, telemedicine programs did not hit the mainstream. But then COVID came. And for me, the first encounter with COVID-19 was on February 2020. When COVID did not arrive yet to Israel. We did not have COVID in Israel, but we heard about a cruise ship, Diamond Princess cruise ship, who was next to Japan. And we had 15 Israelis on board of this ship. And this ship became an incubator for COVID-19. And although there were very, very strict isolation measures, people got infected all the time, and there was a lot of pressure to bring back to Israel these Israeli citizens that were exposed to this new deadly virus. So it was decided that these patients would be brought to Israel, and we had only 3 days to get ready, and they would be brought to Sheba. And Sheba decided to create for them an isolation ward that would be outside of the main campus. And I got the mission to create for them a new system, a new model in which, in this isolation ward, we would still be able to give them high-level medical care, but with minimizing to almost 100% the physical contact. And what we wanted to do is to harness telemedicine tools for these in-hospital patients. Usually we don't use telemedicine tools for hospital patients, but for patients that are afar. And this time, it was meant to maximize the crew protection from this deadly virus. So I knew that the 3 main things I wanted to do was to be able to communicate with them. And I told you before that video was really important for me. I wanted to monitor them, and I wanted to be able to perform physical examination if they deteriorated. And what I did is, since I only had 3 days, I called all the companies that were dealing with communication, monitoring, telemedicine tools, etc., that were operating in Israel. Most of them were Israeli startup companies. And I asked them to sit together and try to find out a holistic solution composed of some of their tools. It was really amazing to see how these companies that are usually competing with each other all took the mission, and we chose a few of the technologies, and together these people worked pro bono for 22 out of 24 hours in the next 3 days. And this is what we came up with. We opened a ward. In every room of the ward, we left screens, we left tablets, we left all kinds of sensing solutions. And we inflated outside of this a tent that usually serves us for missions abroad to go to crisis area. And in this tent, we put all our command center. We called it the teletent. And we put there our medical records, our communication systems, our ways to see the monitors and to see the x-rays. And the medical staff would sit there, the doctors and the nurse, and will conduct most of their work from there with communicating with the patients. This allowed us to do some interesting things. For example, as you can see here, when people did have to go in, when patients started to deteriorate, we used a Taito kit that usually serves for listening to the heart or lungs or watching the patient throw. It's a physical examination kit. We used it to be able to see if the nasogastric tube is in place, and the physician who will listen would be outside in the control room, since we didn't want the physician that's inside to have to take down his PPE and to expose himself. This is one of the examples. Later on, we opened new other wards. Of course, COVID-19 arrived to Israel. We opened an underground ICU. This time we had a bigger control room. And here, for example, we used other technologies like here that you can see the telepresence robots that help us, in this case, again, to decrease the number of physicians or clinicians that have to go inside the ICU. Of course, in an ICU, physicians and nurses have to go in, but it can help us decrease the number of people that have to go in and can communicate from the outside. We did the same trick when we had to open OBGYN COVID-19 wards when the alpha wave arrived. This is, pregnant women started to flow in, having COVID-19 during pregnancy, and we took the technologies that we've heard of, but we still didn't have experience with, and used it in the COVID-19 ward. In this example, you can see a woman doing a monitor or an ultrasound that is point of care and used by the pregnant woman, but guided by the physician who's in the control room. And indeed, we integrated some of these technologies, and now we're using them for women that are going home to continue to be monitored in a hybrid way. Some of the times they do have to come, some of the times they don't have to come, for example, when they have pregnancy. And this is about all our comprehensive telemedicine solutions. So first of all, we took care of isolated COVID-19 patients that were inpatients. I believe I skipped one slide. Anyway, yeah. So this is the third slide. This was one of the programs we did. We took care of COVID-19 hospitalized patients. And then when the first lockdown came, what we did was to ensure continuity of care of our ambulatory patients. We saw then that we had more outpatients that could not continue to come and have our outpatient visits because of the lockdown. And then we transferred in about 10 days all our outpatient clinics to video clinics. We use also our Datos platform. There's a very simple way. You just entered your patient's phone in here, and the patient will receive a link and a phone call telling him that he has to press on the link and be straightly connected to a video visit, a secured video visit, and the physician will be able to work in his office. And sometimes when physicians also were in isolation, they could work from home and continue giving continuity of care to our chronic patients. This led us in the end of 2020 to finish the year with more than 60,000 video visits in Sheba, just to give you a feeling, the year before 2019, we had less than 600 video visits, although we were really trying hard to promote telemedicine programs in Shiva. So this is what we did during COVID-19, and we wanted to see if we're doing right or what can we learn from that, since all the changes were really quickly, and we went out with what we call now, we would say now is a minimum viable product, because we were not integrated with the Shiva central systems, and we just started working on the administrative process. And what we did was really quickly sending clinician and patient experience surveys to our clinicians and our patients, especially our patients. What we saw was interesting. First of all, we saw that patients are satisfied with our video visits. In all the services, about 90% of the patients were very satisfied with this. We asked more specific questions, but they were all around the same answer. They gained confidence, they understood what was saying to them, they felt that the communication was good, and they were happy with these services. In contrast, our clinicians were much less satisfied, and what we could see here is that there were differences between different services. For example, psychiatric physicians were quite happy about it. More than 60% had high levels of satisfaction, and oncologists on the other side, oncology physicians were much less satisfied with this way of working. We believe that some has to do with the administrative burden that these different services have, that made it harder for oncology patients, since they have to, send their many times they have sent to send their patient to other consultations, to other imaging studies, etc. So I believe this caused them work harder than the psychiatrists. And one of the reasons we think is the reasons for them not being satisfied is that although we thought it's really simple to use platform, they didn't find it so easy to use. Only 23% of the physicians and clinicians thought that it's really simple to use. And this told us a lot. Sometimes what we think something, when we start to integrate it, it's completely different, differently overviewed by the clinicians. So this allowed us to do a quick improvement process. We went with our technology company, the platform, to do some technological improvements. We went over the administrative process to make it more fluent. We opened a support system, a technological support system for the physician. And in some of the services, when we had elderly, we had elderly patients that we saw that were having hard times to do it, we put a student, a nursing student, to call these patients before and guide the patient before the visit on how to communicate. Later on, our technological platform improved, and we were able to do it without the need of a student or a person. And the fourth thing that we did is we trained all our clinicians with our medical simulation center. We have in Shiva a medical simulation center that trains all our clinicians. And we made sure that all our clinicians will undergo a course that we created together for training them the best practices and specific communication skills that are needed to perform video visits. We didn't go on to so much on the technological things, but more on the communication skills. And these courses, of course, include frontal teaching, a little bit of what telemedicine is, but what is more important is we're doing live simulation with actors, with true actors that simulate situations that occur between physicians and patients. So we did all this in Shiva during the COVID-19 first wave. And meanwhile, globally, there was an exponential surge both in usage of telemedicine and in investment in telemedicine companies, and really a big surge. I'm sure you felt it as well. And then we finished our first COVID-19 wave with some insights. We understood now that we could use telemedicine, and we had good tools to use it that will allow us to scale. And more importantly, we understood that the world around us has changed. And as regulation gets more flexible, as financial models allow more reimbursement now, other things have changed, and mostly people all the people have used telemedicine platform to communicate, and we understood that we needed to take this a step forward. We understood that the whole world is going to be more hybrid now, not only virtual, not only face-to-face, but hybrid. And we decided to challenge the term of what a hospital is, what continuity of care is. You know, hospital can be no longer a place, a home for sick people. This is the meaning of hospital, no longer a house for sick people. We like in Sheba to say that we're a city of health, that we communicate with the ecosystem, with the city around us. And now when we use telemedicine, we can really treat anyone, anytime, and everywhere. And that's when we established our first virtual hospital within Sheba that we called Sheba Beyond. And this is the hospital that I've established together with many other people, and I'm managing right now. So Sheba Beyond actually relies mostly on Sheba's leading clinician and know-how. So our main asset is Sheba's leading clinician and know-how. And to that, we add cutting-edge technologies, and together with that, we create new models of care delivery that are patient-centered and disease-centered. And with that together, we truly believe that we can change the mode of healthcare provision around the world. So if you look at our online, at our site, you can see that we already have now a wide array of services that we have. We have from hospitalization services to rehabilitation services, consultations, courses, etc. I want to give you just a few examples, and then I will leave time for questions. So one of the things we have developed is a model for patient-centered chronic care management. I believe there's a lot of place in telemedicine, in management of chronic care patients. I already told you in the beginning that I truly believe that the ways that we have now to monitor patients between encounters gives us a lot of information and allows a better continuity of care for these patients. So our models are, first of all, managed by senior specialists, always a senior specialist physician with a case manager nurse. And this case manager nurse looks all the time at the continuous data that are flowing from the patient and does actively reach out the patient. It's not just, seeing the data. We have in all programs a way to actively reach out the patients and see if they're okay. To all of these programs, we give a multidisciplinary team to allow a holistic treatment plan, and we use for each program different telemedicine technologies that fit the disease, the population, and the state. So I want to give you one example of a chronic care management program that we have. So pediatric obesity. We have a very big issue with obesity, I believe, in the United States as well. In Israel, we have 150 children that are defined as obese. This is out of 9 million. And I believe during COVID-19, this number even grew. And you know that for taking care of obese children, you have to make them do exercise to lose weight and change their state of mind and work on their behavior. And for that, we already have in Sheba a multidisciplinary clinic that includes a senior physician, a nutritionist, a physiologist, and a psychologist. And they were starting already to provide telemedicine services before. But now we created a true program for these patients using the DATOS application that we have, smart bracelet that monitors the activity, but moreover, we integrated in it a gaming application that gives physical rewards to these patients to increase their motivations. I can tell you that we have preliminary results of about 50 children in this program, and that more than 90% of them change their feeding habits, and more than 70% of the children already are showing a decrease in the BMI. So we're really happy about this service. Another program that I want to talk to you about is Rehability at Home. Rehability Online is a platform that was developed in Sheba to help our clinician do rehabilitation from home. It is software that helps the clinician do physical, cognitive, and speech therapy. But always on the other side, there's a Sheba clinician. But the platform will allow them to make better activities, to use all their cognitive, what they need to do cognitively. And the platform also allows the patients to train between the visits, and the clinician can see if the patient really trained or just turned on the platform. So it allows also a better continuity of care. This system is working for many years now with thousands of patients, and it's really successful. And now let's go to Hospital at Home. So as you know, Hospital at Home describes the delivery of the entire inpatient acute care episodes that are substituted by hospital in the home. And it's enabled by digital technologies, multidisciplinary teams, and also sometimes ancillary services. The first programs that was operated by Sheba, and I believe it was the first in the world, is the program of Psychiatric Hospital at Home, a service of chronic care management and hospitalization at time of mental health deterioration. So we have in Sheba Hospital, psychiatric hospital with several psychiatric wards. This is Dr. Asaf Kaspi, is the head of one of this department. And he's the initiator of this program. So how does it work? What's nice about this is the bundled approach. The patients will come to the ER due to a crisis, a mental care crisis, and it will be decided that they have to be hospitalized. And this time, we will hospitalize them inside in the ward for 1 day. And during this day, they will meet their clinicians. They will be given a treatment plan. We will see that they're stable and not dangerous for themselves or anyone else. And we will give them a bag with all the technologies they need, a tablet, a blood pressure cuff, all other kinds of things. And then they will go to home hospitalization program for a certain number of days. And here they will talk to they will replace all the encounters that they usually receive in the hospital. They will receive them at home by the same team that met them in the hospital. But what's nicer about it, that when they're discharged and feeling better, they will continue to be managed by these teams for 365 days, for a year. And this, if they deteriorated, they will go back to a more intensive way of treating, also from distance. And if they fail, they will be hospitalized in the same ward. So this gives us a prolonged continuity of care of this patient, and a way to change the intensity of the treatment according to their needs, to their specific needs. So it's really a patient-centered program. We've been having this program for almost 2 years now, with more than 140 patients, some of them now doing the second year already in the same program. And it's going really well. The article will be published soon. What I really like about the programs that we do is that it allows us to break the silos of healthcare systems. So in Israel, we provide care of inpatients, and the community services are provided by 4 HMOs. In Israel's system of healthcare system, all the Israeli citizens must be in one of the 4 healthcare plans that are not only the insured, but they're also the provider of care in the community. And in this program, we join together. This patient named Sean has an inflammatory bowel disease that for which he needed to be hospitalized and monitored closely. And this program that we do with one of the health funds, Maccabi Healthcare, allows him to be at the comfort of his home, guided from distance by Professor Gadi Segal, head of the internal medicine ward in Sheba and head of the hospital at home program in Sheba. And at the same time, physically in his home by Hila, his community nurse from Maccabi Health Funds. So I'm sometimes even more happy about these things, or more excited about these things, because it allows us to collaborate different health systems that usually did not work together. So we've been having this program now with the second health fund. So we have 2 out of 4 health funds already working with us on this program, and it works also really well. We also aim to go globally, since we're talking about decreasing the burden of or the borders, the geographical borders. We now are starting to give medical care to diabetes patients in the UAE. We've made an agreement with Al Tadawi Medical Centers to treat their diabetic patients from afar by Israeli's team. The first time we'll go there, we'll engage the patients, we'll meet them physically, and we'll give them the application and the monitoring equipment that they will need. And then our clinicians will go back to Israel and continue to take care of these patients from distance and see them every now and then. So this is what we've been doing until now. And when I was thinking about, before talking to you about how will you go even further, how do we as healthcare organizations need to think when we want to scale up? So I thought we should talk about 4 things. One, how do we change a hospital structure? How do we adopt our hospital structure to do telemedicine and these programs? How we help regulation to get even more flexible and be able to get reimbursed for these programs. How do we collaborate? How collaboration is important, and just a few words in the end about technology. So in Sheba, we're already working on, we have at least 1 ward on this, and next year we'll be opening at least 2 more wards that are hybrid wards. Will change the way our medicine wards will be. Instead of a traditional ward, this is a sad picture of how a medicine ward looks in the winter in one of the hospitals in Israel. Instead of this, we're going to make our wards smaller, with the same department medical staff taking care of inpatients that are in the ward, and at the same time as patients that are in a house, the virtual beds. The nursing services, as you saw before, will be provided by home services providers or by health fund nurses, and we will use telemedicine services to communicate between the staffs. This will help us to provide continuity of care, since the community services will be taking care of these patients also when they're hospitalized, and it will allow us to extend our hospital's services. So we're already doing it in 1 medicine ward. We're aiming next year to open a pediatric cardiology ward that's hybrid already, an OBGYN ward that's hybrid already. And this is how we see the future of our in-hospital wards. In terms of the hospital organizations, I told you we have 4 hospitals and 2 centers, and it was decided this year that Sheba Beyond will be the 5th hospital of Sheba. And this means that we're establishing an organization that takes care of all these hospital at home programs, and we're working with affiliates in every one of the hospitalizations. So our hospital need not be a big hospital, a big building, but just to be like the command, the center that commands all the activity that happens in all the other wards and hospitals of Sheba Medical Center. How did I get here? Oh my God. Sorry, I'm sorry, just a second. Are we good? Almost. Are we good now? I hope I am. Did everyone fall asleep?
Yes, you're good.
Looks great.
Great. So talking about regulation. During COVID-19, many countries, and these are some examples of what happened in the United States, made temporary changes to telemedicine payment and regulations. For example, it allowed people to get telemedicine services in their home in Medicare and Minnesota. It allowed people not only in rural areas to receive telemedicine services, etc. But now, when we finish now, is the time for permanent regulation changes. And I know you all are aware of the waiver of the CMS about the acute hospital at home, but also these flexibilities that now allow more people to receive telemedicine services or hospital at home services, they kind of block us because they say that only about 60 diagnoses can be hospitalized at home. The hospitalization is only for hospitals, not from the community. They tell us which screening protocols are required and how much in-person attendance is needed, and more and more. In Israel, we face the same problem. We have regulation for only very specific diagnosis, very specific wards, and we need to work on having more and more flexibility. Another thing is that the health plans also are launching now telehealth first options. This is something that will take us forwards. The insurers by themselves will allow telemedicine services, sometimes even that cost less money, and that will allow these telemedicine services to get wider and wider. For this, we need to collaborate. Many organizations have started now collaborating. This example is of Dispatch Health together with Multicare. Multicare is a not-for-profit healthcare organization located in Washington that connected with Dispatch Health, which is a provider of home hospital. And together, they're creating services that will allow better care in the houses, since a big health organization collaborate with organizations that will go to the houses and have the ability to deploy wide mechanisms of giving health in the houses. Another example is the collaboration between Mayo Clinic, Kaiser, and Medically Home. Mayo Clinic invested a lot of money in this collaboration, and they created a very nice system of hospitals at home service that they are now deploying in the United States. But they took it one step forward. They created a coalition, and they asked other healthcare organizations to join them. And this is exactly what they want to do, and I'm trying to do it in Israel as well. They try to bring the stakeholders together to increase the coverage of home care services and to help the flexibility and to make sure that it continues even beyond COVID-19 health emergency. So I think these initiatives are crucial for us around the world. This is the example that happens nicely in the United States. And I'm trying to also lead some kind of thing that's like this in Israel to promote and to make sure the telemedicine or hospital at home services are here to stay and not going away. These are the members that have until now joined their coalitions. It's 11 other healthcare organizations, and I think it's quite impressive. And before I finish, I want to say a word about technology. We've, together with ARC is our innovation hub in Sheba, that does all the research around which technologies should we use, how to implement them in medical care, to give solution and to do pilots with all these companies. And we try all the time to introduce newer and newer technologies. Technology will always develop quicker than we can adapt. We will never be able to adapt technology at the pace that they are developing. And people, the medical world is very, very, old-fashioned. And people might be afraid that using more and more technology will cause us to lose the physical touch, the human touch. And I believe that on the contrary, technology will help us getting closer to our patients, being able to reach our patients in their houses, be closer to them, and to know what happens to them between our visits all the time. And this is what we're aiming for. Thank you.
really wonderful presentation. Thank you so much. We have a few minutes now for questions. You can raise your hand or just unmute yourself. I'm sure there's ideas that you all have. Oh, there's a message here. Let's see, going right into the chat.
I can see your questions. Would you
Okay.
like me to answer the questions that I can see in the chat?
Sure, why don't you go ahead and start with Kai's question there?
Okay, so Kai asked me, so I know that you've been applying to for the CMS waiver now. I believe that already about 150 hospitals have done that already. And could you speak on how to approach the HA eligible patients and help them understand this new care delivery model before they consent? So yes, first of all, we have a nurse that's working a full-time job in the, only during the mornings, not in the evening, in the ER of Sheba, and she's trying to locate these patients. Actively, she goes over there, although we have also people going on over the medical files and looking for, in Israel, it's even less broad in we can only get people that have infections such as UTI, pneumonia, cellulitis, or have CHF and COPD exacerbations, and we can get these patients from the ER or from the ward itself. So we have a nurse that goes over the files and goes over to these to look for these patients in the ER. And I have to say that it's hard for us to find patients that meet exactly the inclusion criteria. This is what's hard for us. Once we get there, so we have, I can say it's about a half people that are afraid to go home by themselves, and they're still not used to that. And sometimes they don't have, they need to have, help in the house. Caretakers, someone that will help them in their house, and not every time we have someone like this. But if they do have, they will agree. The people in Israel now are really afraid to go into hospitals. They know about hospital-acquired infections. They're afraid of COVID. So many of them are really happy to go home. And the ones that are scared to go home will not do so. We also approach patients in the wards, and there the problem is sometimes they're treating physicians in the wards that are skeptical sometimes about these programs and will not want to discharge them so quickly to this program. So we're working hard with between the staffs to explain about the program, to show them our successes, to reach to what we do is the head of the service will reach the head of the ward many times and talk between them and explain to them again and again how this program can help their patients. How does Sheba screen for and respond to home readiness for hospital at home? I'm asking about equity issues as dominate. Yeah, so actually we won't go to their houses and see if they're good enough. Since we do all these programs with the community together with the HMOs, so many times the HMOs will know, and our programs are worked in a way that the HMO nurse has to go physically to the house of the patients at least not more than 4 hours after the patient goes home. And then she can just go and see and monitors, and if something's a problem, and I have to say it didn't happen until now, she can be the one that can raise a flag and say this patient does not have good conditions to stay at home, maybe we should bring him back to the hospital. But I have to say it didn't happen, and that's part of the first visit, the initiation.
Yeah, I have a screen on.
Did you say something, Sharon? Okay, what sorts of outcomes are you assessing to determine whether bundled care approaches from home care are successful compared to standard of care? Of course, we're looking for readmissions. That's we're screening other things as clinical outcomes, medication treatment, adherence to treatment plan. So it depends. If it's a psychiatric, the bundled approach is with the psychiatry patients. So we monitor all kinds of clinical outcomes that are psychiatric outcomes. But of course, we look into readmissions and the cost of care. But we still haven't published these data because we need many patients who have finished this program. And what we're doing now is comparing similar patients who are not in the program with patients who are in the program to see how if we can save money, if we can reduce readmissions, and we check also for clinical outcomes. What were the surprise obstacles you encountered? It seems like your hospital at home has largely been deployed along services line. Which lines were the most successful? So what I showed you before is our outpatient services. So we have many outpatient, the satisfaction process that I showed you was about the outpatient services, not the hospital at home. For hospital at home, for true hospitalization, we only have medicine and psychiatric. So we don't have many service lines. In the outpatient clinics, I have to say I was surprised, but the major success was in the psychiatric services, many psychiatric, psychologic, and this tells us a lot about the ways that can we communicate and can we promote trust using telemedicine service. And I say yes, if it works with psychiatric patients and psychologists, it means that we can make good connections and good communication between a patient and a clinician. The surprise obstacles. Wow, that's a nice question. I'm telling you, I was surprised in the beginning that the physicians were harder than the patients to learn the technology. And sometimes it was harder for them to adopt technologies than it was for the patients, even old patients. And what I was not really surprised, but I know that, but you know, we found that out in real life, that they don't have a lot of patience. They work very hard. They have to have platforms that work really well, seamlessly, with no technological problems whatsoever. And if sometimes it doesn't work as it should work or as easy as it should be, we lose many clinicians that afterwards would not want to do telemedicine to continue. Heart failure, gastroenterology, how about cancer? So yeah, heart failure, we're doing a study now of medication monitoring in patients with heart failure. We haven't started it as a service yet, but we're working on it. We really want to start doing it. Gastroenterology does a lot of outpatient work. We also have programs with gastroenterology that does, we have several programs that do PROMs, also patient-reported outcomes measures. So we use that and in gastroenterology and cancer. We're doing a lot of outpatient work. Now, many of our oncologists have endorsed these outpatient visits with their patients, and they really value it. And we have a lot of work in this, and we're working on starting this next year to do mostly immunological, but also chemotherapy treatment at home. So we're promoting one of them. Maybe if we talk in 1 year, I'll have more examples to give you of adult and pediatric cancer patients that start to receive chemotherapy at home, monitored from distance with our clinicians, by our clinicians. Welcome. Any other questions?
Don't be shy. We've got about 4 more minutes. Have you done any evaluations of the family members who are taking care of these patients at home and how they've reacted to the responsibility of taking care of a patient that is technically an inpatient in a hospital? So
it's an issue. I mean, it's a good question. We haven't done a surveys to assess these family members' satisfaction or the burden that they have. We're really very aware of the fact that placing people in their houses or moving care to the homes of the patients puts a lot of burden on the family members. We know that, and we know that even before making telemedicine programs, since elder population is getting older and older, so many family members are taking care of their parents. And some of the programs that we develop, for example, we are developing now a program for dementia patients, are targeted to help the caretakers, the family members, with their questions, with their difficulties in taking care of these patients that are being hard to take care of in their houses. And we're aware of it. We still haven't studied it, and it's a very good question you've raised. And I'm taking it to for us to monitor in the future. So yes, it's a big burden. We have to address this thing as well.
Are there any other questions, or should I throw one more out there? Oh, there we go. Chow has a question here.
Impacts on increasing market share, capturing new patients. What are your strategies to increase market share through the use of telehealth? Yes. We are what we're trying to do now. For example, as you've been able to see in what Mayo did and other organizations in the United States, they joined together with a provider that works in the community. And we're just now in the process of choosing one of the community providers that are not health funds, that are companies that provide care in the homes. And we're looking for providers that work in the whole country, that have a wide distribution, that will allow us to hospitalize at home patients that are not in our area, our capture area. So we're looking at these ways of joining with a company that not only does it better than us, go to the patient's home, provide the care at the patient's home, but will also be able to do it in a much wider range, geographic range. So we're looking for that. And we're looking also for companies that do already work with the health funds that can bring us patients from other health funds that we're still not working with. So yes, we're looking all the time at increasing our market share, definitely. That and abroad, of course. Welcome.
Fantastic. We have 1 minute left. Any last minute questions? Otherwise, I am going, oops, anyone's hands up? I should look for hands up, although people usually speak up if there's a question. This has really been fantastic, very enlightening on ways that we can advance our telemedicine services through the Chicago area. As you say, you're going abroad with this effort. We would love to expand our market share and use our clinicians and staff and technology to expand and deliver care differently. We have to. We learned that very quickly with COVID, and we need to maintain that and expand it and make sure that we're providing the care that patients need at their home. Thank you very much, Dr. Barkai. Thank you, University of Chicago Medicine. As we noted, that we are in the process. Kai and Jamie, I think, is on here too. Strobel are working diligently to get with a whole team of people to complete our CMS waiver, with hopes for a late spring pilot of hospital home on the south side of University of Chicago. So thank you all. Have a great day, and we will be in touch with more details.
Thank you for having me. Bye-bye.
Of course. We'll be working with you. Thanks. Bye-bye.